Yes, as observant of you will know, I'm not Mary Fallon. It's a great pleasure to be here today and to speak on her behalf. I've been a member of the Cancer Pain subgroup since 2007, and I've been heavily involved in the majority of studies that I'll present today, so I think we're going to take some questions at the end. So, these are the current members of the pain subgroup. When I started, Henry McQuay was actually chair, and presented one of our first studies to him. And it's really changed quite dramatically in the past 8 years, really developing more from palliative care into supportive care or supportive oncology, really. And I think the makeup of the studies you'll see today reflect that. I think if this was the second conference on supportive care, I would be able to present some of the results of these studies, but a lot of these studies are just in the final analysis stage. So if it's successful in another conference next year, we'd hopefully be happy to present some of these findings to you all. So, there are really sort of 4 strands within this group. There's pain management. I've called it supportive oncology, which focuses a lot on optimisation of oncology treatments. There's a lot of our translational work, so for lay members of the audience, that's building on work in animal models or in the laboratory and trying to put that into practice in patients. And also, we've done quite a lot of randomised controlled trials, RCTs, looking at different drugs for pain in cancer. So, a whistle-stop tour, really. I think the first study, which again is finished but not yet published, is the Edinburgh Pain Assessment and Management Tool, EPAT. And the idea behind this study was really to make pain assessment, institutionalised within hospital care, in the same way that as a patient is a monitor for their temperature, their pulse, and their blood pressure, they were monitored for pain in the same way. And this was a study in 19 cancer centres throughout the UK, which recruited 1,900 patients, and incorporated into actually making pain assessment part of routine care. Management algorithms were also integrated, so if patients had poor pain control, pointers were given on the right sort of drugs, both morphine and equivalents or other types of painkillers to try and optimise their pain control. And one of the sort of what we call an outcome measure, how we measure the effect of this, was looking at if we had a drop in a pain score of 2 points on a 0 to 10 score. So a patient had a score of 8, if that dropped to 2, we regard that as being an improvement, and that's sort of widely regarded as being a meaningful improvement in pain. The TVT study, well, this is based on a very simple but widely used algorithm for cancer pain management, which really was developed in the mid-80s by the World Health Organization, which sort of starts patients' pain management on paracetamol, moves on to drugs such as codeine or cocodamol, and then up to morphine. And really, although this WHO analgesic ladder was developed and is widely used, there's really little evidence base to support it. And in fact, there's a degree of evidence now that suggests that if you have pain, it's quite acceptable to be started on a low-dose, strong painkiller such as morphine, and actually you may get better pain control with that. So we are currently undertaking an international multi-centre trial as part of the European Association of Palliative Care Research Collaborative to try and test this approach to see if it's actually more efficient to go straight to a low-dose morphine-type painkiller rather than sort of climbing the ladder, so to speak. And we're running that study in Scotland, a few centres in England, in Mexico, in Uganda, and Israel and India. So that's ongoing. Recruitment stands at 75 at the moment, out of a planned 100. Mike Bennett, I don't think he's here today, but Mike's been an integral member of the pain subgroup, and his study is published extensively, on neuropathic pain and pain management algorithms. And just on Mike's behalf, these are some of the trials and grants he's got running at the moment. A lot of Mike's work recently has focused on simple measures to try and optimise patients' pain control. I think one of his most interesting pieces of work was when he showed that if you told patients how to take their painkillers correctly, they got better pain control. Now that's fairly straightforward, but the improvements in pain he got with that were similar to the improvements in pain we would get from a clinical trial of a painkiller, so he's to be commended for that. Supportive oncology. I'm a consultant in palliative medicine. I have been since 2009, but I see more and more of my work really is in supportive oncology, because I see a role, if we can optimise patients' symptoms, optimise their physical condition, prevent or minimise side effects from anti-cancer therapy, we can help our oncology colleagues deliver anti-cancer therapy more appropriately. And at the end of the day, that's the key matter, optimising cancer treatment for patients. And a lot of what we can do now, I hope, is try and optimise patients' treatments. So a good example of this is the MINT-P study. This is a study looking at menthol for neuropathic pain. And neuropathic pain is a very common problem for cancer patients. A common patient I see is a patient who was diagnosed asymptomatically with bowel cancer, who then has surgery, is essentially cured but receives adjuvant chemotherapy with drugs which contain platinum, and often these patients are left with quite marked chemotherapy-related neuropathy. And the interesting thing about this patient group is they are left with more symptoms after their cancer has been diagnosed, treated and cured than they were before. And it impacts dramatically on their quality of life. So this is a study looking at menthol topically to try and improve these symptoms of neuropathic pain. We've done a proof of concept study for this, and we're moving on to a larger clinical trial. Jackie Stringer, who's a member of the group, is looking at acupuncture for chemotherapy-induced peripheral neuropathy. And I would emphasise that although these treatments such as acupuncture don't have a lot of evidence base behind them, that's a fault of ours for not conducting trials in these modalities, and it's admirable that she's doing that. A trial that we conducted across several centres, we're looking at radiotherapy for treatment of mesothelioma in places like Sheffield, Glasgow, Newcastle, Liverpool. Mesothelioma is a huge problem. And this was a simple study to assess whether actually does radiotherapy help pain when we were giving it for mesothelioma, and that's just been published in the Journal of Thoracic Oncology. And that's a good example of using sort of palliative care and pain knowledge to complement an oncology sort of research question, and it's leading on to a further randomised phase 2 trial. Our translational work, well, a sort of good example of this, if you have a patient who's got a cancer deposit in a bone metastases, and they get radiotherapy, about 1 in 4 patients will get a complete pain relief from that. So that means a large proportion of patients will not get an improvement. And what we want to try and find out is there a way that we can predict which patients are likely to respond to radiotherapy versus those patients who don't? And some of the animal work has translated very nicely to clinical models, which has suggested that if patients have altered sensation to warm or cold stimuli in the area of skin overlying their pain, they may have a greater likelihood of response to radiotherapy. And we're following that up with a study at the moment. I'll just move on slightly. Yeah, interestingly, if any of you have sort of followed events in ASCO, the American Society of Clinical Oncology, over the past few days, you've realised that there's been a lot of sort of groundbreaking work looking at how modulating the immune system can actually treat cancer. And that's something we've been working on as well, looking at how actually modulating the immune system through targeting inflammation can actually treat pain and other symptoms. What we do a lot of the time in cancer or palliative care is wait till symptoms develop and try and treat them. And I think we need to understand symptoms more at their sort of genesis. And targeting inflammation may be one way of trying to do that. And this is a study that we published in Pain, looking at the relationship between pain and interleukin-6. And another study showing that a lot of symptoms in common cancer common symptoms in patients with cancer are related to inflammation. And now we're leading on to other trials trying to modulate inflammation to treat these symptoms. Very brief run through our analgesic agents. One of the problems in palliative care and supportive care is that a lot of drugs become very much ingrained in our current practice without any real strong research to support them, either positively or negatively. Pregabalin's a good example of that. It's been used anecdotally for patients with bone pain, and we've conducted a clinical trial to see if actually pregabalin is a useful analgesic in the treatment of bone pain, and as again the results of that are in development at the moment. Ketamine's another example. This is a drug which has been used for a decade at least now for the treatment of neuropathic pain in cancer patients, but really without any strong clinical trial evidence. So we've completed a trial looking at ketamine for the treatment of cancer pain. And finally, cannabis. Patients have used cannabis for decades for cancer pain. And one of the problems is physicians, we've been unable to prescribe it because there's not been a sort of proper regulated cannabinoid-based medication. But there's been a portfolio of work which marries Laird, and we're running in Glasgow and Edinburgh and various centres across the UK, looking at cannabinoids for the treatment of cancer pain. These trials have all reached their conclusion. I'm not privileged to share the results with you today, but again, it will provide some evidence, hopefully, for the use of these medications. Finally, a couple of things we have in the pipeline. We've got an exploratory study to try and develop a simple bedside tool, which we can use to try and predict which patients may or may not benefit from radiotherapy. We're looking at a trial of paracetamol versus morphine, paracetamol with morphine in patients with cancer pain. A lot of patients who've got advanced cancer will still be taking paracetamol, 8 tablets a day, which is a huge burden for patients, but we don't know if it's providing any additional benefit. So an important basic question that we're looking at. And we're also embarking on a trial of tanezumab, which is a sort of novel anti-immune system drug for treating bone metastases. And as I said, we have a further study looking at radiotherapy in the treatment of mesothelioma. I'll finish on one thing. I believe in the past in palliative care, there's been a sort of reluctance for patients to participate in clinical trials. And I'm of a sort of mindset that the oncology colleagues have, that if you have a patient, if there's a clinical trial they can do, they should be approached about it. They should be considered for it. And we have just published in the Journal of Pain and Symptom Management a study where we've asked patients who've participated in palliative care symptom control trials how they found it. And immeasurably, they all found it a positive experience. Key to that, irrespective of whether they got a benefit in their pain or their symptom in the trial for which they were participating, didn't matter. They found the whole experience of being in a trial very positive. And I think that bodes very well for future research in our area. So thank you very much.